folks. Welcome to another work from home episode of Long Shots. And today we have with us Dr. Arun Chopra. A lot of you already know him. He has been an active health and fitness writer on Transfin, but that's his night job. His day job is he's a senior cardiologist at Fortis Amritsar. And in these troubled times from a public health perspective, it's great to have a medical man with us to, throw a bit more light on COVID-19, on the mechanics of the disease, on, issues which we are facing specifically in India, be it testing, be it PPEs, and we won't let him go without throwing a bit of light on, how we can actually improve our own day-to-day living under a lockdown, whether it's through better diet, it's through exercise. I'm tremendously excited to have Dr. Chopra with us, and obviously before we bring Dr. Chopra into the conversation, a big hello to Mr. Sharad Chopra. Hey Sharad, how's it going, man?
It's going very well, and I'm also very excited for today's chat because we've covered RBI, we've covered interest rates, we've covered so many things coming from COVID, but the biggest thing, the first thing on the front burner aspect is health. So I guess we can touch upon some of those nuances there today.
Absolutely. Dr. Chopra, welcome on the show.
Thank you, Nikhil. Hi, Sharad. Nice to be with you guys once again, even if on phone.
Yeah, so we were kind of having an internal joke that our podcast frequency has increased because that also gives us an excuse to just, chat.
Sure.
No, but I mean, it's great to have you here. It's great that you could find some time. So, Dr. Chopra, before we kind of go into the specifics, it's been now more than 21 days since the nation went under a lockdown. Obviously, a few states, including Punjab, kind of took more preemptive action from the perspective of restricting movement of people. We know the numbers. We know, the way the disease is. I mean, I don't claim to say that we know, but at least there's a lot of data coming in terms of how the disease is progressing. And I imagine you have almost a front row seat into a few aspects. What's your overall take on the spread of COVID-19? I'm sure there are some things which have been done right, and I'm sure there are some things where there are significant gaps. But if I ask you, as a high level summary of where we are, how would you put that?
See, Nikhil, this is very relevant and perhaps has been discussed ad nauseum on various fora in the last few weeks. But to give you a brief summary, cases started in China maybe towards the end of November, early December, most likely by early December for sure. They did not let out that there was any sort of epidemic going on till well into January. And in fact, till second half of January, WHO was reiterating that this is not a pandemic and other countries need not get worried or close borders with China. In any case, we had our first case in the last week of January, around 27th or 28th January, when some people came from China to Kerala. I think the first case was around that time.
Right.
After that, many people came from abroad in last week of February, early March, because by then panic had set in. By then, not really panic, but a concern had set in. People had got to know that there is this disease which is entering other countries. By end of February, Europe, I think, was well under, and even US citizens were getting concerned that they are going to see a big chunk of cases of COVID because many people I talked to in US were telling me that they are not really prepared for it.
Right.
Anyhow, I think it was in early March that we started seeing some regular inflow of patients, though it was only a trickle at that time. You could count them on your fingers, the number of cases which were coming per day.
Right.
That's why when the PM chose to announce a lockdown, it was actually relatively early in the onset of the epidemic in our country at least.
Right.
But it was a good decision in the sense that elsewhere we had seen both the result of countries where they had enforced strict control in whatever way. Some countries chose lockdown, others chose frequent testing and wide-ranging testing and isolation of contacts. So we chose to do both, which was, I think, quite a good decision since ours is such a massive country with a huge population density. So locking down in towards 21st or 22nd March, along with very rigorous following up, in the sense that people who were coming from abroad, who had any contacts with foreign citizens, they were all checked up and they were quarantined and isolated. A lot of effort went in. The government machinery has been working overtime on the last 4 weeks, trying to isolate all the people who came from abroad so that the disease does not spread. Despite that, despite all the actions, as you can see, the last few days we have been seeing at least 1,000 or more patients being diagnosed new every day.
Right.
So this shows that if this is the case with a very strict sort of lockdown which we have in our country, along with the relatively rigorous following up, isolation of contacts, checking of contacts, you can imagine had this not been done, the number of patients might have been much more.
Right.
Having said that, we are still not out of the wood. As you know, our case number is already in excess of 17,000 confirmed cases.
Right.
We have more than 500 deaths, and the way things have shaped up in Europe and America, at the moment it is hard to say what will happen in the next 2 to 3 weeks, because see, some parts of the country have started to open up today.
Right.
As you know, it's I think for Punjab, for instance, a curfew has been reimposed till 3rd,
Yes.
but there have been certain clear exemptions which have been given. For instance, harvesting is now being allowed, which means this is quite a big affair. If you know about Punjab, this is the main business time of the year, because
Right.
this is the time when there will be hundreds and thousands of labor coming into Punjab, helping in the harvesting part, getting all the crop to the mandis, and there the agents and government and the farmers are again going to meet and sell. The government is going to procure the crop,
Right.
and as you know, this is quite a massive enterprise, and only time will tell. I'm sure the government has an action plan in place, but only the next 2 weeks will tell us how the disease behaves when we relax these restrictions.
I mean, but that's a very interesting, obviously in terms of chronology, like where we are right now. But I mean, I recall when the lockdown was announced at the nationwide level, there were around, I think, a couple of hundred, 400 or 500
That's right.
active cases, right?
That's right.
And now from there we are at around 17,000, and deaths around 559. And one of the there is a version about how accurate these numbers are. Like, let's leave that aside for a moment.
Sure.
But these are relatively small numbers, albeit they have fast-growing trends, but no, they are not comparable to the way the disease kind of progressed in the US or even parts of Western Europe. But
Right.
there's a big kind of school of thought which says that in India the lockdown was not an option; it was something that had to be done because
Right.
the rest of the armory that one has is not very significant to start with. Be it access to good quality, equitable public health care, at scale. So
Right.
the strategy that was followed probably was that let's do an aggressive lockdown to buy some time, right?
Absolutely.
But now the economic costs are obviously showing their own head. So as a result of that, there is some sort of a phase-wise restriction which is kind of going away. What I really get, I think, and this is something that I have spoken with you about, I have spoken with Sharad about, is that there's obviously a narrative about testing, right? And
Yes.
I understand testing at a scale of numbers which we have in India is probably not feasible, and hence a targeted approach is required. But the important thing about testing is that testing provides an exit plan. It provides an exit strategy, right? It kind of scales up how big the problem is. And I know that I think in terms of testing also, things are now changing. Now, I think a few days back only, 2 or 3 days back only, rapid test kits had arrived, and it's expected that testing will scale up much more aggressively. But if I were to ask you as a medical person to comment on the testing strategy against COVID-19, do you buy the approach that has been followed so far, or do you differ from that approach?
Okay. So, Nikhil, while taking note of the fact that I am an epidemiologist primarily. I am just a doctor who is reasonably well informed and part of the COVID team of my hospital.
Right.
So with that, disclaimer, I will give you what I think. There is no doubt that the strategy for testing in India could not have been the same as it was in the West for, several very obvious reasons. One, our population is much more. Two, our resources are much lesser, not only in terms of test kits, but also in terms of hospital beds available, doctors available. So for us, as you yourself said, in the initial thing, we had nothing much other than a lockdown to try and control our numbers. Because see, if hospitals in Europe or hospitals in US were getting overwhelmed in 4 to 6 weeks of the epidemic, consider what would have happened to us, knowing that we have 4 times the population of US and we have less than 1/10 of the hospital beds. So you can imagine that if numbers had mounted on the similar proportion, we would have been overwhelmed in March itself. So I don't think that the initial strategy was wrong. I think the initial strategy was right, in that there was nothing much more we could have done.
Right.
Regarding testing, I think ICMR took a considered view. There were two views which were going around. One view was, random population testing.
Right.
The other way was to look at contacts of people who have been exposed.
Right.
Which meant people who have come back from abroad, that means Indian citizens coming from abroad, or people who went from India abroad in that time when they were exposed in March and came back to India. So all these people and their immediate contacts were checked. And I think in the initial part, this is quite a reasonable strategy.
Right.
Because, in the early part of this lockdown process, if you remember, ICMR Director Dr. Bhargav gave a statement also that they had done random checks in the population. They had checked about 2,000 people in the middle of March. These were random people in the population and they were all negative.
Right.
And that's why in the, I think, second week of March, they announced that as of now, there is no evidence of community spread in India.
Right.
However, that is no longer relevant today. That is not true. Now we have community spread because now we have had so many hot pockets that now community spread is well established. I don't think there is much doubt that in most places, not in all states, but in the heavy states, the states where there are lots of numbers like Maharashtra,
Right.
like Delhi, like perhaps even Madhya Pradesh, Rajasthan, Tamil Nadu, all these places, there is significant evidence of community spread or phase 3 of the epidemic as they call it.
Right.
So now it was very important to increase the number of tests that was being done every day. And I think in large part that has been done. And which is why we should not get very worried by the increased numbers in the last 1 week. I think the strategy was that on 7th, 1 week before the lockdown was to come off, the frequency was increased.
Right.
And based on the results in those next 5-6 days, the PM and the various chief ministers, they all decided to continue with the lockdown as the numbers actually started increasing as the frequency of testing increased. However, having said that, it's important to note also that the number of tests which are coming out positive in India are only about 5%.
Right.
If we look at the total number of tests done, which I think are now close to 4 lakhs, and if we look at the number of confirmed cases, which is around 17,000-18,000, you can take note that the total number of positive tests are about 4.6%.
Right.
So if we compare this with, let's say, US even now has a 20% positivity rate. They are doing 1,45,000 tests per day for the last couple of weeks. In fact, the reason they say they have plateaued is because they are now not performing more than 1,45,000 tests a day, and they are continuing to get 20%.
But I just want to kind of make one point here. Like when we are saying that the conversion is around 5%,
right?
I mean that is like that this kind of corroborates with the government's data that for after testing 22 patients we are getting 1 positive, right?
Approximately.
So, but a criticism of that figure has been that, number one, it has been a plateaued number for the last few days. And the reason why it's plateaued is because it's still bound by the restricted test protocol. So that number might actually go up now, right? In terms of...
It has gone up. If you take note, in the last few days, it has gone up because, like I told you, the number of tests done was increased from at least 7th.
Right.
And once more after that, because ICMR added a couple of more criteria for testing some week or 10 days back. Initially, they were not checking all serious acute respiratory illnesses.
Right.
Now they are checking also, they are doing tests in them also, even if they have no history of contact. And now they have also allowed checking of all influenza-like illnesses.
Right.
Even if they have no history of contact. A third subgroup which has been added is anybody who dies of a respiratory illness, even if it was apparently not COVID clinically, but if somebody dies of a respiratory illness, now even in those people, testing is being done. So this may not be achieved 100% of the time because of, the lot of logistic problems you have with healthcare in India, but nevertheless, the frequency has definitely increased. And the number of tests being done daily, I think, are now coming close to 50,000 in the last couple of days. 50,000 per day, which is a fairly good sized number.
Correct.
Though much lesser than the number that is in US, but I think our prevalence or the number of people who have the disease in society is still much lower than what it is in US. So we are much below what their prevalence was 2 or 3 weeks back. So considering we were thought to be about 2 weeks behind US in this epidemic, I think for that we've done fairly well and our numbers are still much more in control. If you consider 10 days back, US was getting over 25,000-30,000 positive cases per day.
Correct.
Which is the massive number, more than 30,000 in fact. Now it's around 25,000-30,000. In New York, even till 2 days back, the positivity rate was more than 50%. Can you imagine that? So if you check 100 people, 51 or 52 were coming positive. That means that the number of tests being done in New York are very inadequate. And that is why they are changing the figures of presumed COVID death. I think you would have read that in the newspaper. Sorry, please go on.
No, doctor, that's fascinating. I was, the way testing is something that, everyone talks about it and there are so many views on it, like, less testing, more testing, someone says test. But obviously, like you said, right, there are so many nuances. But the timing of testing, right, that itself can also swing the number dramatically, right? I mean, just if like the number of symptoms you're exhibiting, if that test takes precedence, or if you go to a hotspot and then do testing, the numbers can swing around based on what kind of sampling you're doing for the mass testing, right? I mean, that's also a key variable.
Right. No doubt about that. See, I'll tell you, till about 1 week back, these 3 subgroups were not being tested, which I just told you. Now we know that if you do test in all serious acute respiratory illnesses, about 2% of them are coming out positive for COVID. So that's not a huge number per se, but surprisingly, for this time of the year, we are having too many respiratory infections. I have mentioned this earlier, I think, when we were talking, I and Nikhil, that for this time of the year, we are having too many respiratory infections, even lobar pneumonias, typical bacterial pneumonias. These are things you find in winter, in December, January. Or these are things you find in summer hardly ever, and then too in people who are immunocompromised. Not in normal individuals, but we have, relatively healthy adults in their 50s, 60s, even 40s coming with respiratory infection, which is odd for this time of the year, and they are not typical of COVID. This is something which is relatively surprising. Maybe it is because this time weather has been much worse than it normally has been. We still don't have proper summer, at least in my part of the country. We had heavy rain a couple of hours back. In the night, temperatures go down to about 18 or 19. So Maybe it is because there is sun for 5 or 6 days. It becomes warm. People, start behaving as if it's summer, and then seventh day there is rain. It becomes chilly again. Maybe it's because of that. I don't know. But people with respiratory infections are coming, and it is essential to check them for COVID, even if they clinically are not looking like COVID. As I was just telling you, a few out of them are turning out to be COVID. Then people who die, of acute respiratory infections within, let's say, 24 hours of coming to a hospital. Especially not to a big hospital where we can get a lot of investigations done quickly. We can get an X-ray, echo, a CT scan of the chest. We can get it done within a few hours of the patient coming to the hospital. In my hospital, for instance, or in any big corporate hospital. But if you go to a small nursing home in a peripheral town, you would find that it's hard to get investigations done early. And if a person lands up with respiratory illness and dies in a few hours, probably maybe even an X-ray would not have been done. So it's important to capture these patients. And I think the good thing is that for the past few days, all these patients are getting covered. Perhaps not all, because there is reluctance on the parts of relatives to get testing done, because under the Epidemic Act, if you send a test in a patient, you can't hand over the body to the patient's relative. So the hospital has to keep it in a mortuary, their mortuary or a city mortuary, whatever, till such time as the test comes. And only when the report comes as negative do you hand over the body to the relative. If the report comes as positive, then you obviously inform the district authority, who will then take over from there. So because of that, there is reluctance on the part of relatives to get tests done in such patients, who just came to the hospital and died shortly after some episode of shortness of breath. But we are trying now to enforce this, to get these patients checked, so that we get to know what is the proportion of these patients who may be having COVID.
And another fascinating theory, or for lack of a better word, is sort of how in India the demographic is one factor, but the other being that we've got vaccination for TB and I think polio, or as children, and the US doesn't have that mandatory vaccination. A lot of Western countries do not have that. So there is that theory that maybe that also is a factor. Are those is that kind of thinking also something that needs to be explored further, or is that something that you can just ignore for now? Like, are those factors, like how important are such factors, like which took place years and years back? I mean, for someone who's in their 50s, they probably got that vaccination 50 years back. But just out of curiosity, are factors such as that important?
Sure, Sharon. See, what is important is that probably if you look at the non-specific immunity which Indians have living in India, I think it is definitely more than people living in the Western world. See, if you and I go to Europe or America, we don't fall sick because of anything. But when those people come here, they are likely to get diarrhea and respiratory infections, and which is why you see they are very careful about what they are eating or drinking. They all carry mineral water bottles in their hands. So they are just not used to a lot of these allergens, a lot of antigens which are moving around in the air, and a lot of non-specific infections to which we are actually used to, because we have all had puri chola or dahi bhalla or golgappas at the neighborhood ready wala. So that is one factor. Another factor is BCG, which you very rightly asked. BCG is an immunostimulant or an immunomodulator. It modifies the immune response, and definitely there is some evidence to show that BCG improves the immune response of people against certain infections as well as certain cancers. In fact, to give you an example, in urinary bladder cancer, in some varieties, to prevent a recurrence, BCG is actually injected inside the urinary bladder. So it does have an immunomodulatory role, and it must be helping in some way. Now, how much is that help? It is hard to say. Because see, typically what has happened is that countries which are having huge spread are countries which don't get BCG regularly. They are countries which are much more hygienic and have overall a better quality of life, and generally they are not used to all these infections. And third, they are living in temperate climate. Their climates are much cooler than the climate in our country, and because of this, the very popular term R naught, or the transmission of this disease, is much more efficient in those countries because of cool weather also. On the other hand, in India, we have all these factors. We have a lot of non-specific immunomodifying factors. We have BCG type of immunomodulating factors. We have warm weather, which is known to reduce the transmissibility of this or any respiratory infection for that matter. So, see, even in summers, flu does occur. But the transmission of flu is not as efficient as it is in winter. So, similarly, in our country, there are these maybe three and maybe several other factors which have been contributing to the fact that in the warmer countries, which are also less developed, which have more impurities in the air, and who have got BCG vaccination, we have less cases. Whether it's in Asia, whether it's in Africa. On the other hand, in the more developed parts of the world, we have more cases.
But
you can choose your pick.
The thing is that a lot is not known about the disease as well, right? I mean, we are kind of discovering a lot of things on a daily basis. Because especially when you were earlier making the point on the respiratory conditions or the rising respiratory conditions with which people are coming, I mean, even when it comes to the protocol, when it comes to dealing with COVID-19, I mean, I was reading somewhere that like especially in the US, there's this big discussion whether at what stage do you put in the ventilator, like whatever are the thresholds which are kind of applicable in acute respiratory distress syndrome, whether those same threshold are applicable on COVID in terms of the degree of symptoms or asymptomatic I would say evidence that comes out. A lot of new things are coming in. Then we also keep on hearing of like I think it was in South Korea that a few of the people who were cured, there was a relapse, they again got diagnosed as positive. I mean, I'm sure you must be deep into the medical literature, and unfortunately probably at this stage most of the papers which are coming out are not peer reviewed, so there must be a lot of speculation, a lot of opinions flying around. But in the days which have gone by, what are the things which really surprised you when it comes to looking at this disease?
Sure. See, one thing which is very important is we never used to have this sort of connectivity earlier. When last time when we had these epidemics, MERS did not happen in our part of the world. It happened more in Middle East. But SARS was there, and then swine flu came to India. We didn't have this sort of connectivity. We didn't have so much of presence on social media platforms. There was no WhatsApp, and therefore information didn't travel so fast. Now information travels so fast. If I get one article on one group somewhere, you can just be very sure that in the next 2 days I'll get that same article on 10 different groups, because everybody is getting that information from somewhere or the other. So I think the whole information goes around the world in 2 or 3 days. There is hardly anybody who's actively pursuing something who will not manage to find whatever he's looking for. So there is so much information traveling. The other thing, as you very rightly picked up, is the fact that many of the articles, the medical articles, are becoming posted on WhatsApp, have not actually been peer reviewed. See, this is a process which does not normally happen. Normally, once you have done a study, you have written an article, then you send it to the editorial office for review. And this review process typically takes 4 to 6 weeks. And then, if accepted, the article is published maybe months later. Most good journals have a waiting list of 6 months or more before they'll publish an article which has been presented to them. So what is happening now is, because of this unprecedented crisis, articles are being uploaded without peer review. And that's why we are not sure how dependable this information is which is coming out. And that's why you would have seen that so many things have changed in the last couple of weeks. We used to be very sure of something, but just a couple of weeks later, we now know they were not valid. So, to give you an example, 2-3 weeks back, hydroxychloroquine was the biggest thing in COVID. It was given for treatment, it was being given for prophylaxis, that means as preventive strategy. So, that is still continuing, but now the confidence that people had 2-3 weeks back is somewhat shaken by the fact that the more randomized data which is coming in is not so rosy.
Right.
It does not show dramatic response the way the first couple of studies which came out of France and China did. And therefore, we have a surfeit of evidence, but we don't have a quality control as to how solid that evidence is. And that's why when we talk about managing patients who need ventilators, we tend to fall back upon our old hardcore criteria which we follow. For instance, in USA, what they are now doing is, see, here we don't have so many cases that we have any problem about admitting patients.
Right.
We are even admitting asymptomatic patients with COVID positive, even if they have nothing,
Right.
just so as to quarantine them effectively. But in US, where the healthcare system is overwhelmed, they have given clear criteria. Anybody with a respiratory infection, if
Right.
their saturation is above 94%,
Right.
he is not to come to the hospital.
Okay.
Because even if he comes to the hospital, he will not get admitted and he will not get tested. So please let that sink in. If the saturation is more than 94, he has a respiratory illness, fever, cough.
Right.
If he does not have saturation below 94%, he will not be admitted into a hospital and he will not be tested.
Right.
Therefore, even the numbers which they are showing are actually less than the number they have in population, which is why just as China corrected its mortality a couple of days back,
Yeah.
even New York is thinking of modifying the mortality figures which it is presenting, because there have been so many deaths in the last few days for which people were just not tested. They just did not have the opportunity or the resource to get tested. So we are following conventional criteria for managing ARDS or adult respiratory distress syndrome so far.
Right.
People have noted, see, we haven't seen so many patients, but people who are managing in US and in Europe are regularly updating us. We have lots of friends there as to what are the differences between these patients who go on to need a ventilator and between conventional respiratory failure or respiratory infection patients who go on to need a ventilator. And I think everybody who is managing COVID patients is now quite familiar with those ideas. So it is not a huge difference, but
Right.
there are some differences which we obviously can't go into, this being a non-medical platform.
Right.
But I think most people know about it and they are working about it. They are, trying to prevent ventilation as much as possible.
Right.
Because even in a technically advanced society like US, the mortality of patients who go on to ventilator is 80% or more.
Right.
Further, the problem is that these people are not getting weaned off ventilators.
Right.
So what is happening is they go on a ventilator. It looks as though they are doing better, but you are not able to take them off ventilator. Normally, for routine respiratory infection, we try in 3, 4, 5 days to take them off the ventilator. But here, typically, patients are needing 10 to 14 days or even more of ventilator before they can actually come off. And as you were just mentioning, it has also happened that patients have been extubated, the ventilator removed, they have become negative for the viral load, the
Right.
PCR test, they have been sent home and
Right.
then they have come back again with positive results, as you were mentioning just now.
Yeah.
And people have even come back and died suddenly of cardiac arrest. So there are things which are going on about which we are not really clear, but what is, I think, happening is that people become positive when they start nasal shedding.
Right.
This virus basically homes into the lung first.
Right.
Then after it's entered the lung, it infects some people very mildly or not much at all and they have no problem. In others, it spreads over the body. It's only when it reaches the nose, the area behind the nose,
Right.
the nasopharyngeal area, that's when nasal shedding starts. That's when these people, when they sneeze or they cough, they, push the virus outside, and which is then available to infect other people potentially. So there are probably people who are continuing to show nasal shedding till late. Earlier it was thought it's going to end at about 2 weeks, but now we find even at 3 and 4 weeks, people have continued to shed.
You mean
both
like
symptomatic as well as asymptomatic?
You mean like I think the incubation period is supposed to be 14 days. So even after that, you are infecting.
Yes.
Potentially.
No, this is not incubation period. Incubation period is the time between you get an infection and you manifest the symptoms.
Right.
This is basically the time when it is presumed that you had contact. That means the time when one got the infection. And after that, it was thought that within 2 weeks or so, nasal shedding should stop. But now we see that's not the case. Between 3 to 4 weeks, many people are continuing to come as positive. You must have noticed there were a few celebrities in whom, testing was being done repeatedly. And even 4 times the tests came out to be positive. And they became negative after 3 to 4 weeks. And surprisingly, these people are sometimes totally asymptomatic. So what it means is that if you don't quarantine them, they can go around and infect so many people because these people are evidently well. That means their immune response has managed to keep the virus under control, but not wipe it out. It's staying in their body. They are shedding it. People are getting infected from it. But since these people have a good immune response, they are not symptomatic. And this is what is happening in young children, in young adults who don't have any other, comorbid conditions like diabetes or hypertension or heart disease or renal failure. So these people are healthy people. So they are infecting other people, but they are not affected themselves. They are totally asymptomatic. So this is the real problem with this virus.
But if you
it's important.
if you have to break down the timeline, I mean obviously for an asymptomatic person it's very difficult. But say someone with symptoms, I mean, from if you look at the person gets infected, then from that period there will be some time lag when the symptoms start showing, and there will be some time lag when transmission from that person starts showing up, and then there will be a timeline after which the infection, I mean, presumably is is over. How much, and I'm kind of obviously cognizant of the fact that a lot of these cases require prolonged hospitalizations, right? I mean, what is and obviously because we are kind of, when we are looking at a thing like a lockdown, we are kind of extending it or contracting it by weeks or a few days. But what is the typical, I won't say textbook because there's no textbook on this particular disease as of now, but based on what is the most common trend profile?
Sure. That's a very important question. And unfortunately, as I told you, there are many imponderables here. See, broadly, what we thought initially in the initial days and weeks of this epidemic, we thought that once the patient gets infected on day 0, people start becoming symptomatic by day 5 or so. The median time of developing symptoms was day 5. So people were becoming symptomatic within 1 week of getting the contact with an infected person. So they were getting infected, they were becoming symptomatic. Then this fever or some cough, some upper respiratory symptoms would last for a few days, and most people would become, asymptomatic within 1 week of onset of symptoms. That means the whole illness would last probably around 2 weeks. However, there were lots of, features that were relatively strange about this virus. One was the fact that people started becoming infective before they become symptomatic. This was rare. This usually does not happen. Usually people with either viral illnesses like, let's say, chickenpox, etc., would become symptomatic only when they either become febrile or when they have the rash, or maybe a few hours before the development of the rash, maybe 12 to 24 hours before the development of the rash. But this one, it showed infectivity even 1 to 2 days after the initial contact and much before symptoms developed. This was one uncomfortable fact. That means if somebody starts developing symptoms on day 5, 6 or 7, he may have been infected for 3-4 days earlier, which is, very odd, and which there is no way of really protecting or finding other people from such a person. The other thing was that gradually we saw that at 2 weeks the viral shedding is not ending.
Right.
So we found that the protocol has been that once you find a patient to be positive, you repeat the test every 1 week after that. And if you get one negative test, then you perform a second test 24 hours later.
Right.
And you say that a person is cured only after he has had 2 negative tests within 24 hours.
Right.
This means that you are trying to rule out intermittent shedding.
Right.
That shedding was present today but not tomorrow, or present today but not yesterday, something like that.
Right.
But now what we find is, which is odd, that even some people are continuing to shed this virus for 3, 4, even as long as 5 weeks in some cases. In rare cases, 5 weeks, which is massive. But average has been around 3 weeks or so. The other thing is,
so that kind of extends the period to almost 5 weeks.
Yes, the course of the disease gets extended to at least 3 to 4 weeks. The other thing which is uncomfortable is that people are passing this virus even in their stool, their motion. This was something which was not found with the previous respiratory viruses.
Right.
They were transmitted only through oral secretions or nasal secretions.
Right.
But this one is getting transmitted even through the orophageal route, which is another uncomfortable problem. So this virus has got several odd points which were not present with the earlier viruses, which is making it harder for scientists and researchers to understand it, and harder still to manage it. And still, see, it is early days. It has been just over 2.5 months that this virus has been present in the world outside China. Already there must be thousands of publications on this. We have so much information, but see, not enough time has elapsed to let us know hardcore that okay, this is what happened. This usually takes several months or years of data. Data is analyzed, and you know what is happening. So the time has been too less. It's just that the number of cases are so large that there is a large opportunity. Many people are researching this, but there is so much rapidity of publication that everything we are getting is not reliable. But broadly, you can take it from me that the illness does not last just 2 weeks, but definitely can last 3 weeks, sometimes even 4 weeks or more.
Wow. And what do you think the timeline could be for a potential vaccine? Like, will it be a 2021 event, or do you think there is a possibility of a vaccine that can come this year as well?
Oh no, that is unlikely. This year it will not come. See, the earliest vaccine trials in humans started last month. They started in the second half of March. It takes months and months to try out on significant numbers. See, there will be first a small number of patients, then a higher number of patients, then there will be toxicity studies. All this has to be done. Only then, if international agencies then approve of that vaccine, there will be bulk production. See, as of now, people would be producing hundreds or thousands of vials, because nobody will invest so much to make 1 billion vials of this vaccine and find 1 year later that it's useless. So nobody will manufacture 1 billion vials today. But remember, we are going to need several billion vials when the vaccine actually starts. So companies will have to upgrade their facility to manufacture the one vaccine or 2 vaccines which actually, bear out on the test of time. So this is going to take months and months, and all authorities have been commenting that it is going to take at least 12 to 18 months for this whole process, provided the vaccines which are being tried out now work out. It is possible that they may not work out. Supposing they do not work out, then you see the search starts once again. It again resets. It becomes 12 to 18 months from the time the next trial starts. Because see, if you look at another RNA virus, which is the HIV virus. Now we know we have many effective drugs against AIDS, because of which it's relatively much more under control. But see, we became aware of AIDS in the 80s. It's been 35 years, and we still don't have a vaccine against HIV. So it is possible that the vaccines which which are being tested now may not come out positive. They may fail. And if they fail, or if there is too much toxicity, then the search starts again. So don't expect a vaccine anytime this year.
This seems like when you said HIV obviously led to some very permanent changes in human behavior.
Right.
There is a very good chance that this particular pandemic will also cause different changes in human behavior.
Absolutely.
Be it in terms of traveling, be it in terms of work. If you look at things in a very immediate fashion, I just wanted to get your sense, number one, on the entire issue of PPE for healthcare workers, for frontline workers, which is, I think, a super critical requirement at this stage.
Right.
Because if the healthcare workers themselves get sick, then it obviously will reduce the overall impact of any strategy which is being deployed. From a PPE standpoint, we obviously as general laymen, we keep on reading about different companies, different volunteer organizations who are trying to scale up production of PPE, but I'm guessing that it is still a big gap when it comes to the
big challenge.
But obviously you have been looking at this over the last 1.5, 2 odd months. Do you see things improving in that particular regard? If there is, or do you see something which is being missed from that perspective by policymakers?
Initially, I think all the PPE kits which were available somehow just vanished. I hope they were all purchased by government agencies, because whatever was available in second half of March, suddenly it vanished from the market. I'm in a private hospital, and when we tried to procure kits in the second half of March, suddenly no standard company available in India had these kits available.
Right.
But then people got working. And now I think many manufacturing companies which were manufacturing other things have begun manufacturing several types of PPE kits. Some of them are, of course, ridiculous, but there are others which are fairly decent.
Yeah.
See, if we compare the ideal PPE kits which we should have, the level 3 PPE kits, we don't perhaps have so many of them.
Right.
As for instance, you see videos coming out of China. I don't know whether they reflect the large reality on China or whether they just reflect what they allowed to come out. But what we saw were absolutely waterproof, one-piece, full-body suit.
Right.
These are often not available. We have several modifications which are not absolutely waterproof. We often have water repellent material with which we are making these kits, using material with more than 90 GSM or something like that, which gives us how water repellent the fabric is, and which will prevent water from coming inside the kit. However, I think at the moment we are okay, at least in the hospitals where we are working and we are trying to procure these kits, we are able to procure.
Okay.
So at the moment, I think in the last 2 weeks, in April, the supply has improved and we are now getting kits. If we want to buy kits, we can buy them.
Right.
There may be others who may not want to buy, that's another issue. Some people who are elderly, who have smaller nursing homes, may choose not to work. And that is okay, because everybody has to take his decision based upon his situation. But we want to buy kits, we can get them.
Right.
The problem is that it's also not easy to work in these kits. Now see, for the last 2 weeks, I have been doing all my procedures wearing a level 2 or a level 3 kit. And it's quite cumbersome.
Right.
It takes so much time to don this whole kit. It takes longer for me to do the procedure because your movements are restricted. The vision is not optimal because you are wearing glasses, you are wearing screens, they tend to get fogged up, and you just can't work with the hood because the hood keeps moving, impairs your vision. It's much harder to do a procedure. So see, I'm doing less procedures than I normally do, but the ones which I do take me about 1.5 times as much time and as much effort as they would normally take.
Right.
So it's really, not easy. It's changed our life absolutely. As you said, life is going to change. Life has changed for patients and life has changed for us.
Yes.
Each patient is looked upon as a suspected COVID
Potential
patient.
COVID.
Yes,
Yeah.
and the first couple of hours are, spent in trying to rule out COVID while
Right.
just giving the patient symptomatic relief.
Right.
Because, nobody wants that you take up this patient into an OT or a cath lab and find out tomorrow that this patient is actually COVID positive.
Right.
In fact, half the hospital and, next day the whole hospital will close down.
Right.
This way, soon we'll have no hospitals left to take care of patients who need our help, whether they are COVID or they are non-COVID.
Right.
So these are big problems. Anyways, you were talking about PPEs, and PPEs in private hospitals we are able to buy.
Right.
In government hospitals, I'm not sure about how much the availability is there, because in some places I find that people are getting adequate PPEs, but in many hospitals, resident doctors especially are not getting the optimal type or number of PPEs.
Right.
There has been a crisis even about the availability of the required mask. N95 mask, I think, has become a household name.
Yes.
N95 masks are not so easy to get. Even we are having difficulty. We are, rarely able to get the 3M N95 mask, which is the standard.
Right.
Sometimes we get 3M, then other times we get companies which are not so good, but we are managing to get.
Right.
But in many government hospitals, people are not able to get N95 masks, and that's the problem. Because, but see, what to talk of India, even in the Western world, in Europe and in US, healthcare workers are working without PPEs and without N95 masks.
Right.
So even they are overwhelmed.
Well, like from there, I just have one more, I would say, last point to kind of pick your brain about. That is, you mentioned non-COVID in between. Two things. I think there must be a behavioral shift in a lot of people from a healthcare perspective who are actually COVID negative, in the sense that I recall you were mentioning, when it comes to people with hypertension, people with heart conditions, a lot of them are waiting for some time before they go to the hospital. So as a result of that, often when it comes to non-COVID related ailments, there is kind of a side effect which is creeping in. There are deaths happening because of that. There are people who are ignoring medication. And secondly, so I just wanted to ask, on this platform, if there is some, some wisdom you would like to share with the general listener base who's plugged in. From that perspective, that would be great. Secondly, obviously, you have been actively commenting on health and fitness related issues in general. Now, we all are in a lockdown, so from a lockdown perspective, generally, I think both diet and fitness generally take a toll when people are limited indoors. Any non-medical advice for them? That would also be pretty, I think, handy.
Okay, so addressing your first question first, see, it is, I think, a very relevant issue. It appears that the number of people with non-COVID related illnesses are also not presenting to the hospital these days. While, lots of articles have been written on where have all the heart attacks gone and where have all the strokes gone. But let me give you a perspective into what is happening. See, what has happened in the last few weeks is the whole world is on lockdown practically. The whole world, as we know it.
Right.
So what is happening is that people are staying at home. They are not working under the usual stressful circumstances. They are not communicating, so not facing traffic jams. There is much lesser pollution. Smoking is finished. Almost nobody is smoking. Alcohol has come down significantly. Alcohol-related, illnesses have come down significantly. People are washing their hands regularly.
Right.
So they are getting less stomach infections. People are keeping masks on their faces. So they are getting less respiratory infections.
Right.
Schools, colleges, and any place where there are large get-togethers, all these places are closed. So we have less of chest and stomach related infections in young children also.
Right.
Young children have actually become much healthier. They are not becoming ill at all. So we have so many aspects. And one thing, there are no accidents at all. See, since there is no speeding, no traffic on the road, there is almost no roadside accident. Now, just look at this, that if we look at what are the daily number of accidents happening, we have some 400 people, 400 accidents in a day in India, leading to some fatality. On the other hand, the total number of fatalities of COVID is as yet less than 600.
Right.
So imagine that the number of accidents which we are saving, accident-related deaths, is actually many times higher than the number of COVID deaths which have taken place so far.
That's a very positive take, I must say.
Yes. So our overall mortality, if we look at the mortality, in India, it's just below 1 crore, or 10 million in a year. Right. It's about 9.8 million.
Right.
So imagine that about 26 or 27,000 people die every day in India of something or the other. So we've reduced the mortality due to so many other things so much.
Right.
That even despite this COVID-related mortality, the actual mortality is actually lower than what it normally is. This is one important issue. The other thing is that because of the fact that people are afraid of going to big hospitals, they are either not going to hospitals at all if they have no COVID-related symptoms.
Right.
That means if they have chest pain, if their BP is somewhat high, if their blood sugar is high, they are not going to the hospitals to get a checkup done because they are afraid that in big hospitals there will be people infected with COVID, and if they go to the hospital, they are likely to get infection.
Right.
So either they
that is probably leading to some amount of non-COVID mortality, right? Which is avoidable.
Right. That's what I'm coming to.
Yeah.
That because of that, people are either staying at home with their complaints, or they are going to, small clinics or small nursing homes in their area, but not to the big hospitals where there are actually better facilities to manage these illnesses.
Right.
Because of this, we are having some non-COVID related morbidity and mortality. And for them, my message is that if you have significant symptoms relating to any illness, please don't avoid going to a hospital. See, generally avoid going out, that's good. And if you have to go out, or if you have to go to any place, even if to get your groceries, or to the hospital, you wear mask.
Right.
See, even in the hospitals, we are being very careful. Like we are running our OPDs, but we are very careful about how we segregate our patients, how we see them. We try and do our best to make sure that neither they nor the hospital staff gets infected one from the other. And therefore, if they have any serious problems, whether it is to do with heart disease, high blood pressure, diabetes, kidney problem, any tumor or malignancy, they should not avoid going to the hospital if they feel they are having a problem.
Right.
They must go to the hospital and get appropriate treatment. And that is very, very desirable.
Right.
The other part which you were talking about was what sort of dietary and exercise guidance I can give you. See, the point is that activities for everybody have come down.
Right.
So normally, if you are eating a healthy diet, your appetite should also come down. What I mean is that you shouldn't make use of this time in hogging on whatever is available at home. Rather keep your habits healthy. So what can we do? If we take, normal healthy diet, healthy foods, like for instance fruits, vegetables, milk and milk products like curd or cheese, if we take nuts, seeds, all these things, legumes, dal and stuff, all these things are very healthy. They can all be taken in adequate amount. At the same time, if you take non-veg, you can take eggs. If you take eggs are healthy. They have a lot of healthy protein and fat. They are good for the immunity. You can also take non-veg chicken if you have a good source that is available.
Right.
But please remember that other immunity boosting foods are basically fruits, vegetables, nuts and seeds. And if you take eggs, then eggs.
Right.
All these are healthy. Then if you take, there are lots of Ayurveda practitioners who are advising things like garlic and ginger and stuff like that, and I'm sure those must be healthy too.
Right.
So they can be taken, with advice from professionals. I'm not the right person to advise you about them, but they must be having their own benefits. Then you must continue to do some form of exercise. If you are at home, you are not able to go to the gym or the park, that doesn't mean you can't exercise.
Right.
You'll find that, if you have a passage outside or if you have a roof on which you can walk, that's good. For smaller cities, that is quite a healthy practice.
Right.
For bigger cities where this may not be practical, where people live in multi-story apartments, you will find a variety of exercises which you can do with just your own body weight.
Right.
On the net, on Google, and on various sites. For instance, if for young people, doing push-ups or pull-ups or body weight squats or mountain climbers, these are very, very useful activities. You just need to spend 15 minutes doing these, and you'll find you'll not only break up into a sweat, you'll actually become breathless and tired, and you will end up building some muscle also.
Right.
So what I mean is that just because you are at home, you should not think that you should stop exercising. And finally, the two last immunity boosters are, one is adequate hydration.
Right.
Take adequate amounts of water, because summer is now here. We should take lots of water. And finally is adequate sleep.
Right.
And this is a time in which I think adequate sleep is now available to most people. You must remember that good sleep, which should be 6 to 8 hours per day for a healthy adult. Normally it's around 7.5 hours. So adequate sleep in a 24-hour period is very important to boost your immunity. And therefore, if you have the sort of healthy diet that I was telling you about, do some exercise regularly, hydrate yourself well, sleep well, and have a generally healthy mental attitude, you'll find that your chances of getting these viral infections decrease significantly. And even if one gets them, recovery is likely to be much faster and much better. So these are some of the things which I can, suggest to all the listeners as to which could be useful for them in the next few weeks and months.
Excellent. I think that was very encouraging and helpful as well. What I'll do is I'll obviously put a link to the I think there was an article written by you on bodyweight exercises on transfer.
Right.
So I'll put that link in the description. And
right.
So I think it's also a good time to introspect, but it's important to have a routine and kind of follow the healthy and fit protocol which Dr. Chopra just laid out. Dr. Chopra, thank you so much for giving us your time, and it was, I think, very illuminating. We had a fairly in-depth conversation. I think we have crossed an hour as usual, Sharath. We never realize it when we are doing it.
It really flew, and this subject is of great interest, especially in this timing. It's something that I don't know much about, so it's always a pleasure to learn new things. So thank you so much for your time, Dr. Chopra.
Thank you, Sharad, and thank you, Nikhil. It was great being with you guys as usual, and I loved having this nice talk with you. And if it helps your listeners, that will be great too. Thanks
perfect.
a lot.
No, thank you so much. And yeah, with that, I think it's time to call it a day. This is Nikhil Arora. I have with me Sharad Chopra, and we are signing off.